Welcome to the Attention Deficit Disorder Expert Podcast Series by Attitude Magazine.
Hello, everyone. I'm Carol Fleck, and on behalf of the Attitude team, I'm pleased to welcome you to today's ADHD experts presentation titled Eating Disorders Comorbid with ADHD, What You Need to Know About ARFID, Anorexia, and Others. This week is National Eating Disorders Awareness Week. To recognize this important issue, Attitude has partnered with the National Center of Excellence for Eating Disorders to bring you today's presentation. The National Center is the nation's first center of excellence dedicated to eating disorders. It was founded in 2018 by the Substance Abuse and Mental Health Services Administration. Its mission: to improve the education and training that healthcare providers receive and to promote public awareness of and treatment for eating disorders. Leading today's presentation is Dr. Christine Peat. She's the director of the National Center of Excellence for Eating Disorders. Dr. Peat is also an associate professor of psychiatry at the University of North Carolina, Chapel Hill, and a licensed psychologist. At UNC, she serves patients with eating disorders, supports healthcare providers in the UNC Wellbeing Program, and provides behavioral medicine interventions to patients in various medical settings. In today's webinar, we'll talk about the symptoms and treatments for different types of eating disorders. Research has mainly focused on eating disorders like anorexia, bulimia, and binge eating disorder. Others, including avoidant restrictive food intake disorder, or ARFID, are understudied in comparison. Our expert will talk about these relatively new diagnoses, how to address eating disorders in people with ADHD, and when you should seek a specialist for clinical care. So without further ado, I'm so pleased to welcome Dr. Christine Peat. Thank you so much for joining us today and leading this discussion.
Hello, everyone. Thank you so much for having me here this afternoon or perhaps this morning, wherever you might be. I'm really pleased to be here to talk to you all a little bit about eating disorders and specifically a couple of diagnoses that maybe don't always get as much attention as some of the others do. And I'll spend some of the time during our presentation today really focusing on the intersection between eating disorders and individuals with ADHD. So I'm really pleased to be able to give you information that I'm hoping will be really practical and really helpful. With all of that said, I wanted to kind of unpack a few things before diving into some of the heart of the presentation. So first and foremost, why even talk about eating disorders? Why is this a topic that's worth discussing with an audience like you all who primarily focus on attention deficit hyperactivity disorder? So just in terms of giving you a little bit of the scope, eating disorders are conditions that affect roughly 28 million Americans at some point in their lifetime. That's almost 9% or a little above 9% of the US population. So we're talking about a significant number of people who will at some point struggle with some form of eating pathology. And I think that that's a number that a lot of people are sometimes surprised by, because I think that unfortunately there are these stereotypes about eating disorders affecting relatively few people, them being kind of rare conditions or disorders. But in reality, the data that you're seeing here are actually ones that were published back in July of 2020 in collaboration with Deloitte Economics and a few eating disorder programs. And so, those data are really telling us that these are much more common than maybe we might have once thought. Unfortunately, eating disorders are also conditions that are deadly. That same report reported that somewhere around 10,000 people will die each year as a direct result of their eating disorder. So kind of sobering when we think about the fact that these are common and also really life-threatening. In addition to that, eating disorders are conditions that have an enormous toll on the US healthcare system. So Deloitte is an organization or a company that I'm sure many of you are familiar with. And what they did was they actually looked at the overall cost of eating disorder treatment in a single year. And what you can see here are several different numbers. The first is the total healthcare system cost, and that was around $4.6 billion associated with the treatment of eating disorders. And that's going to be everything from, routine primary care visits all the way through needing inpatient hospitalization for folks that are really acute. And that's that far right number that you might see, $107.6 million for those of you who might be listening in. In addition to the actual cost associated with treatment, the Deloitte report found that eating disorders also have a significant impact on society, the American workforce, and businesses. So when you think about it, this might be people who are taking time off of work to seek treatment. Maybe these are people or parents or caregivers who are taking time off of work to care for a sick loved one. These might be people who are maybe needing to take multiple days off for different doctor's appointments, even if they're not going into an inpatient treatment setting, for example. And so what they found was that if you added up all of the treatment costs, in addition to all of sort of the social or economic costs associated with eating disorders, these conditions cost the US economy $64 billion in a single year. So I just want to pause and sort of have you reflect a little bit on that number. $64 billion in a single year is an astronomical cost. So I think what I'm trying to do here with this overall foundation of information is to really lay the groundwork that eating disorders are conditions that are common, they are life-threatening, and they are costly. And so I think it's important that when we're having these conversations about eating disorders and other mental health conditions, that we're thinking about how much more complicated that gets when there are 2, 3, 4 different diagnoses on board at a single time. So in addition to maybe sort of demystifying some of what we think about when it comes to eating disorders, I also wanted to do a little bit of myth busting when it comes to these conditions. Unfortunately, for many years, and even still to this day, there is a very strongly held predominant stereotype about who is affected by an eating disorder. The stereotype that most of you are probably familiar with is that of a young, cisgendered, white, fairly affluent female. That tends to be the mental image that people come up with when they think about who struggles with an eating disorder. But that in reality reflects the smallest proportion of people who may be diagnosed with these conditions at some point in their lifetime. Because we know after decades of research that eating disorders do not discriminate. They happen to just about anyone, irrespective of your sex assigned at birth, your gender expression, your race or ethnicity, your sexual orientation, your economic status, or your ability status. It's one of those sort of equal opportunity disorders. It's not something that I think that's not necessarily a fact that we relish in, but I do think it's really important that we're doing everything we can to sort of debunk that old stereotype, that old myth about who looks like they have an eating disorder. One thing that I think is also really important is to think about the fact that eating disorders also occur throughout the lifespan. These are not conditions that only affect children and adolescents. These are conditions that for some people, they might have started in childhood and adolescence, but they may have sort of continued to stay the course throughout adulthood. There are also some individuals that will develop their eating disorder in adulthood, having never struggled with anything like that in childhood. Above and beyond all of that, we also know that eating disorders don't have a particular look. You do not have to be underweight in order to have an eating disorder. You also don't have to be overweight or struggle with obesity in order to have an eating disorder. Eating disorders can occur in all body shapes and at all weights. So when we're thinking about who we should be screening, how we should be thinking about how these disorders present, I think it's really helpful to do some of this myth busting so that we're trying to remove some of those old stereotypes. And maybe we're starting to think about other people, either in clinical practice and our community and our families, who might be struggling with eating disorders. And it's when we start to do that we start to do a much better job of screening for these conditions and making sure that folks are really getting plugged into the care that they need. So with all of that said, I think to sort of just drive the point home a little bit further, although there might be a particular image that comes to mind when you hear the term eating disorders, the reality is that it's much more likely to see the people that are pictured here on the screen. These are people of different age ranges, body sizes and shapes, people of different races and ethnicities. These are people that are in your community. They're your neighbors, they're your family members, they're your colleagues. So I think it's important that that's maybe the stance that we're holding as we're starting to think a little bit about these conditions. Now, with all of that in mind, I do want to do just a little bit of quick review on what eating disorders are and how we define those conditions. Mostly today, we're going to be talking about a couple of conditions that maybe don't get as much airtime as others. But since we're going to be talking about eating disorders as a whole, I do just want to do a quick review to make sure that folks have a shared understanding of what eating disorders are when we think about them clinically, at least. So when we think about eating disorder diagnoses, I've actually intentionally started here on this screen with a diagnosis that some of you might not be familiar with, but is actually the most common eating disorder diagnosis. It's what we call other specified feeding and eating disorder, or OSFED. This is essentially people who are not meeting criteria or full criteria for any single eating disorder. They might not meet every single diagnostic criterion for binge eating disorder. Maybe they don't meet every criterion for bulimia nervosa. And this is actually the most common eating disorder presentation. These might be folks that have a handful of symptoms from one disorder, a handful of symptoms from another disorder, and that kind of puts them in this OSFED category. The other diagnosis that I've listed right below that is what's called binge eating disorder. And this is a diagnosis that I'm sure many of you are familiar with. But part of why I've decided to list it in this order is that binge eating disorder is actually the second most common eating disorder diagnosis. If we were to take OSFED off the table and really just look at the full threshold diagnoses, binge eating disorder is actually the most common. And when we think about binge eating disorder, I want to be really clear here that the defining feature of this diagnosis is having these recurrent binge eating episodes. These are people that are having these binge eating episodes where they feel out of control. They cannot stop eating once they've started. And oftentimes they feel guilty, ashamed, or disgusted with themselves afterwards. Anorexia nervosa is another condition that many of you are probably familiar with. And I want to be clear here too, that the defining feature of anorexia nervosa is not actually being underweight or thin. The defining feature of anorexia nervosa is a fear of weight gain or a fear of fat, such that people become so afraid of that they end up eating less and less throughout the day or throughout a period of time. And some of those people may become very thin or underweight. However, one of the diagnoses that we'll talk about here specifically is what's called atypical anorexia nervosa. And this is a diagnosis that we really think about as anorexia nervosa in higher weight bodies. They have all the same sorts of signs and symptoms as somebody with anorexia nervosa, except their BMI may never get significantly low. And we'll take a more close look at that here in subsequent slides. Bulimia nervosa, again, is another diagnosis that I'm sure many of you are familiar with. And the defining feature here is, again, those same sorts of binge eating episodes that we might see in binge eating disorder. But they're usually then paired with something that we call an inappropriate compensatory behavior, where someone is sort of trying to get rid of or make up for the calories that they've eaten during that binge eating episode. Commonly, these are things like self-induced vomiting, abuse of laxatives or diuretics, sometimes exercise. And again, this is something that I think most people have some sort of conceptualization for. The other diagnosis that we'll talk a little bit more at length about today is something called avoidant restrictive food intake disorder, or ARFID. And the defining feature here is a persistent and pervasive eating or feeding disturbance in which someone is simply not meeting all of their nutritional needs. Now, for those of you that are listening closely, you might be thinking, well, how is that different than anorexia nervosa? Isn't that just what she talked about? But really, recall that in anorexia nervosa, the defining feature is that fear of weight gain, a fear of fat, so that individuals intentionally stop eating, right? Or they eat very little. In avoidant or restrictive food intake disorder, or ARFID, these people don't necessarily have that fear of fat or fear of weight gain. These are people who are failing to meet their nutritional needs for lots of other reasons. And we'll talk about some of those here shortly. So I wanted to take a closer look at the diagnosis of atypical anorexia nervosa. It's something that currently is classified as part of that OSFED category that we talked about. But for sake of argument, what I put here on the screen are the current diagnostic criteria for anorexia nervosa. Criterion A is having that dietary restriction, meaning that you're just not eating a lot throughout the day, or you've cut out whole food groups, leading to a significantly low body weight. And we can talk about what that means, but I'm just going to leave that term there on the table for now. The second criterion for anorexia nervosa is this intense fear of gaining weight, or an intense fear of becoming fat, or for some people, behaviors that interfere with any sort of weight gain, even though they know they're at a low body weight. And then the third criterion is this disturbance in self-perceived weight or shape, or a lack of recognition of the seriousness of low body weight to begin with, sort of that body image component, right? What I've put here on the right side of the screen are the diagnostic criteria for atypical anorexia nervosa. And what you can see is that they're the exact same as for anorexia nervosa, except for the weight criterion, except for criterion A. So these are people that are having the exact same eating disorder cognitions, the exact same behaviors. These might be people who are eating as little as 1,500 calories in a single day. They may be having the same sorts of intrusive thoughts about their body weight and shape or about food as people who are at a very low weight. But this diagnosis is one that oftentimes flies under the radar because there aren't necessarily physical manifestations of it. So these might not be people that are at really low BMIs. And in fact, for many people, these are individuals who start at higher body weights or live in larger bodies. And so when they lose a fair amount of weight, let's say they lose 30, 40, 50 pounds, they may inadvertently actually just get congratulated for their weight loss because our society is really focused on fighting obesity and is really focused on sort of weight management. So because of that, when a body gets smaller, but it started at a larger place, those individuals are at real risk for never being detected with atypical anorexia nervosa, even though it is a very serious condition. So with all of that in mind, what might be some of the warning signs or symptoms associated with atypical anorexia nervosa? It's one thing to see a set of diagnostic criteria on the screen, but it's different to think maybe more illustratively or a little bit more concretely about what those signs and symptoms might be. So one thing you might notice in people is skipping meals or maybe eating less than what is typical or what's needed for the individual. You might see that people are kind of pushing food around on their plate, or maybe they're, eating very small portions in comparison to what they typically did. Some people also explicitly express a fear of gaining weight or being perceived as overweight. For people that live in larger bodies, weight stigma is a real thing that they are dealing with on a daily basis. And there may be a desire to really protect themselves from some of that weight stigma. So they might be really focused on losing weight, even in really risky ways. Many people also have this sense of distorted self-image, or they'll be really critical of their own body weight or shape. Some people find that they're really preoccupied with weight, food, calories, fat grams, all of those sorts of things that are kind of common in a dieting mindset. And there may also be things like a refusal to eat certain foods. Maybe they cut out whole food categories like carbs or fats, those sorts of things, in an effort to, again, try and limit what they're eating throughout the day. I want to be clear here that the signs and symptoms that you're seeing, these are not sufficient to diagnose an eating disorder. These are not sufficient to say that someone has atypical anorexia nervosa, because you might see lots of these signs and symptoms and somebody is perfectly healthy. There really isn't any other sort of eating pathology going on. But I think collectively it's helpful to have some sense of these signs and symptoms so that you have something to kind of be thinking about in this discussion. I wanted to do the same closer look for the diagnosis of ARFID. So what you're seeing here on the screen are the diagnostic criteria for this condition. And what you can see, and it's a little bit dense, so I'll try and unpack this for us, but in criterion A, what you can see is that there has to be a feeding disturbance that presents as a failure to meet appropriate nutritional needs. So that's kind of a dense statement. So essentially what I would say is that there's something off in someone's eating pattern or eating habits that's leading them to not get enough calories, nutrients, vitamins in throughout the day. Now, when I mentioned before that there are some different types of ARFID, or different types of reasons why people might not be meeting their nutritional needs, what you're not seeing here is a few of those reasons. Number one, some people may find that they are simply not meeting their nutritional needs because they don't prioritize eating. Now, I want to say here, this isn't, I just got busy at work one day and ended up skipping a meal, or, I worked through lunch, whatever it might be. That's not what we're talking about here. That's a pretty common thing to have people experience. What we're talking about are these people who are saying, I feel hungry. I have hunger and satiety cues, but I just don't care enough to get up and make a meal or get myself something to eat. I just can't motivate myself to do that, right? And this isn't a one day or a 1 week kind of thing. It's a pervasive, persistent pattern. There are also people who are not meeting their nutritional needs because they have real issues with the sensory characteristics associated with food. So those might be things like the texture, the smell, the taste, the shape, the color. Any of those sorts of things might lead people to start routinely cutting certain foods out of their diet to the point where they can actually become malnourished. And then there's a third category of people with ARFID who find that they are not able to meet their nutritional needs because they're afraid of some of the aversive consequences of eating. So these might be people who have had a choking accident in the past, or maybe they've had really bad bouts of stomach upset or GI distress in some way, such that they've learned that if I eat, I'm going to have stomach upset, or if I eat, what if I choke? And that leads people to stop eating so that they become malnourished in some way. So again, when we think about that feeding disturbance, it might show up in a lot of different ways, but universally what we're seeing in ARFID is that this might be associated with weight loss, significant nutritional deficiency. Some folks are relying entirely on things like tube feeding or nutritional supplements, and almost invariably people are having really significant impact on their psychosocial functioning. We also want to be clear here that when it comes to ARFID, what we're talking about here in terms of dietary changes, this can't necessarily be something that's a cultural practice, because we wouldn't diagnose somebody with that if it's a part of their religious belief or a part of their cultural heritage. And you can't actually be diagnosed with anorexia nervosa or bulimia nervosa and ARFID at the same time. These are mutually exclusive diagnoses. The other thing we like to note is that when it comes to this kind of eating disturbance or feeding disturbance, it can't necessarily be explained by another medical disorder. So for example, if somebody is going through chemotherapy, it's not at all uncommon for them to have changes in terms of their appetite, not being able to feed themselves well enough. So it has to go above and beyond what might be expected in a medical condition. Or if it's just the medical condition, then it would be a reason to rule out a diagnosis of ARFID. So similarly to what we did when it comes to the atypical anorexia nervosa diagnosis, we'll talk shortly about signs and symptoms associated with this condition. However, I got ahead of myself. I did go on to explain the 3 different proposed subtypes of ARFID here on this slide. And what you can see is basically what I went over just a moment ago about there being a sensory type of ARFID, where folks are concerned about the different sensory characteristics associated with food, people who have a lack of interest in food or eating, and then those folks that are afraid of those aversive consequences. They have that fear-based reaction to food. And so you might be thinking about people in your life who, have a diagnosis of ARFID, and you might think about, what kind of category they tend to present with. When it comes to possible warning signs or symptoms of this condition, what we know is that there can be things like a sudden refusal to eat foods that somebody once ate really regularly. The term that we often hear from patients and from families is that there were certain safe foods, things that they knew that they could eat day in, day out. It wasn't going to be hard for them. But sometimes those safe foods change, and they can change on what sort of seems like a whim, right? There might be things like eating very, very slowly, appearing distracted while eating, or even forgetting to eat. Some folks with ARFID are very specific about how the food is prepared, even specific brands, certain shapes of food. So, commonly we'll hear things from children or adolescents with ARFID who will only eat one very specific type of chicken nugget. It has to come from a specific brand. It has to be a certain shape. It cannot be any other shape. It cannot be any other brand. Sometimes at certain restaurants, I will only eat the chicken nuggets at this particular restaurant and from no other place, even though cognitively they may know that it's all chicken. It's all still a chicken nugget of some sort. There's something about the eating disorder that doesn't allow them to sort of do that in a rational way, right? And again, for children and adolescents who might be struggling with this condition, that prolonged malnourishment may lead to stunted height or weight. So it's really important to be trying to catch these conditions early. So with all of that said, what do we know about ADHD, ARFID, and atypical anorexia nervosa? How do these work together? Or how are these conditions that sort of might co-occur or overlap? So I wanted to present some of the data. And what you're going to see here in the subsequent slides are a number of different data points with respect to these overlapping diagnoses. And what you can see here is that overall, if we think about eating disorders as a whole, so not just ARFID or not just atypical anorexia nervosa, there is significant overlap between those with ADHD and those with eating disorders. This is probably not something that will come as a surprise to many of you here in this audience, but I think it's important to note that these come from large population-based studies. So this isn't just a small cluster of patients in Nebraska or a small cluster of patients here in North Carolina. These are from samples that are representative of the entire country. So those of us that are researchers often feel much more confident about the numbers that we see when they come from populations that are more reflective of the entire community throughout the US. What one of these studies found, or several of these studies found, is that adults with ADHD were almost 3 times more likely to have been diagnosed with an eating disorder than their non-ADHD peers. In a very similar vein, adolescents with ADHD were up to 3 times more likely to have had an eating disorder at some point in their lifetime. So we're talking about magnitudes of risk when it comes to eating disorders if you're somebody that already carries an ADHD diagnosis. We also know that ADHD comorbidity varies by diagnosis. So when we look at the literature, we're thinking about all eating disorder diagnoses. The highest risk for an eating disorder diagnosis, if you've been diagnosed with ADHD, is for binge eating disorder. So those folks that are having those recurrent type of binge eating episodes. The second highest risk is for bulimia nervosa, and the third highest risk is for anorexia nervosa. Again, these are based on large population-based studies throughout the US. What you're seeing here in this next slide is sort of a visual representation of some of what I described in the previous slide. What you can see here are a couple of different graphs. On the far left, you're seeing 2 different bars. There's a dark gray bar and a light gray bar. And the dark gray bar is those with ADHD. The light gray bar are those without ADHD. And what you can see is that the individuals with a diagnosis of ADHD are significantly more likely to have been diagnosed with any clinical eating disorder. These authors actually looked at specific eating disorder behaviors, and they looked further at comparing those same 2 groups, those with ADHD and those without ADHD. And what you can see in the middle of your screen is that for individuals who are experiencing binge eating episodes and purging behaviors, so self-induced vomiting, fasting, those sorts of things, those sorts of purging behaviors, what they found is that those with ADHD were, again, significantly more likely to be struggling with those sorts of symptoms than people who did not have ADHD. And the same thing is true when it comes to restrictive behaviors. When we talk about restrictive behaviors, we mean things that are consistent with anorexia nervosa. So eating very little calories, limited variety of foods. And what, again, you can see is that people with ADHD are at much greater risk than those without for restrictive eating disorder behaviors. Now, when we think a little bit more specifically about atypical anorexia, some of you might be wondering, well, what's the overlap there for that specific diagnosis? The challenge is that there are very few data regarding the comorbidity between ADHD and atypical anorexia nervosa. And there's a number of different reasons for this. Number one, atypical anorexia nervosa is just a newer diagnosis. But above and beyond that, as I mentioned before, it's a diagnosis that's very likely to go undetected. It flies under the radar, so it's hard to catch in the first place. But above and beyond that, because of the ADHD literature and that documented risk for binge eating, most of the literature focuses on binge type disorders in the context of ADHD. So there's just very little data for us to go by. With all of that said, though, the data on ADHD and restrictive eating, so that might be, again, calorie counting, calorie limits, eating a limited variety of foods, there are some data on that, and they're more meaningful. What one of these studies found is that adults with ADHD are up to 5 times more likely to report restrictive behaviors than their peers without ADHD. The restrictive eating behaviors that they were looking at in this study were things like using weight loss pills, fasting or skipping meals, and expressing that fear of gaining weight or a fear of fat. Interestingly, there are some data that also suggest that hyperactivity symptoms specifically may be associated with restrictive eating. But what's even more interesting about that is that they only seem to find this relationship among boys and men, but not in women and girls. So this idea that that hyperactivity kind of profile may actually be more associated with restrictive eating, but we tend to see this really only in boys and men and not necessarily in women and girls. Now, I want you to take that with a grain of salt, though, because these studies are very new. They're based on very limited data. So I wouldn't take this as sort of gospel truth. But what I would say is that there does seem to be this interesting association. And I'd be happy to take some questions about that towards the end of the presentation today. When we think a little bit about the comorbidity between ARFID and ADHD, again, there's pretty limited data here. As I mentioned before, just like with atypical anorexia nervosa, ARFID is a newer diagnosis. So by nature, we just have less data available about it. And again, the previous literature has really focused on binge eating, overeating, and obesity, especially in the context of ADHD. And so because of that, restrictive eating disorders may not necessarily be the primary focus. So if there was a study looking at ADHD and eating disorders, maybe they didn't even bother to ask the restrictive eating disorder questions. Maybe they only looked at binge eating, for example. Let's see. Is this going to work? Yeah, there we go. Okay, so what we do know, however, is that some early evidence indicates that there is an increased risk for ARFID among individuals with ADHD. In fact, one study reported that 10% of children and adolescents with ARFID had also been diagnosed with ADHD at some point in their lifetime. And interestingly, if you remember some of those subtypes that we talked about, there was actually a specific association where they found that those with ARFID and that sensory subtype, again, those folks that have difficulty with the sensory characteristics associated with food, that particular subtype was associated with a greater than 2 times the odds of having any kind of current or lifetime neurodevelopmental or disruptive disorder. So again, that may not necessarily be ADHD specific, but if we think about sort of the spectrum of those disorders, we're finding that maybe those folks with the sensory sensitivity may be at particular risk for that type of neurodevelopmental or disruptive disorder. Another of those studies found that 26% of adults with ARFID also had a concurrent diagnosis of ADHD. So that's a pretty staggering number there. That's, essentially 1 in 4 people that are going to be having a comorbid ARFID and ADHD diagnosis. And then there was also another study that looked at children receiving inpatient treatment for an eating disorder. And they found that those children with ARFID were also more likely to have ADHD than those individuals who had anorexia nervosa. So very commonly for inpatient treatment of an eating disorder, it's usually folks with anorexia nervosa who are at a very low weight. And now more and more commonly, children and adolescents with ARFID who have lost so much weight that they've become malnourished and they have to go to the hospital. And so this study was looking at both groups of children who are on their unit, and they found that those with ARFID were just more likely to have an ADHD diagnosis. So collectively, what are some of the clinical implications of this? Well, when I think about it concretely, I think it's important to really think about those with ADHD being at risk for a variety of eating disorder thoughts and behaviors, not just binge eating. So, if you've seen presentations before, or maybe you're reading different literature, that doesn't mean that the old literature is wrong. I think it's just that it's too narrow. It doesn't widen out enough to maybe adequately capture what's true for everyone. Also, based on the literature that is out there, it sounds like children with ADHD should be monitored for eating disorder symptoms while they're children. And then again, throughout their adolescence and well into adulthood. Again, just knowing that number of 3 times as likely to have these diagnoses, both in childhood and adolescence. Also, keep in mind that in clinical contexts, ARFID and atypical anorexia nervosa may be overlooked even in very routine eating disorder screenings. Again, we've talked a little bit today about how there's been kind of this predominant focus on ADHD and binge eating or obesity. And so those that have that kind of hyperactivity presentation may actually sort of be protected from eating disorder screening because they're thinking, well, these folks are the hyperactive sort. They're not binge eating. They're not overweight. So why would we even bother to screen for an eating disorder? And it gets even more complicated for males because males are already at risk for not being screened for eating disorder because of that old stereotype that we talked about before. So again, with all of that in mind, I think it's very clear that we need some additional research. We need to know more about these conditions and how they work together. But the emerging evidence would really indicate that there is a real risk for eating pathology across the spectrum, not just binge eating. So, what can you do if you're worried about a child or a loved one? The next several slides have lots of different resources. And for those of you who might be listening in versus attending here by video, I want to underscore that you'll have access to these slides and all of the hyperlinks that are embedded in them. So, please don't feel like you have to memorize any of the websites that we're talking about here. But if you are interested in learning more, of course, I'm going to plug our website, ncdus.org, so that you can learn more about eating disorders, screening protocols, what you might do if you're a loved one or a family member. All of our resources are available for free. There's also an organization called Feast. I can never remember the acronym, but it's Families Empowered and Supporting Those with Eating Disorders, I think. And they are exclusively a parent and caregiver organization. They are just a fantastic group that does everything they can to equip parents and caregivers with the skills that they need in order to support their loved one as they're going through an eating disorder. They have a caregiver toolkit. They have like a 30-day course that you can just get like a lesson per day into your email. And they have support groups specifically for parents and for siblings of people with eating disorders. So really just a fantastic organization. The National Eating Disorders Association is another organization that many of you, I'm sure, are familiar with. They have a lot of free resources and educational materials on eating disorders, as does the National Alliance for Eating Disorders. And in fact, they have a whole landing page on how you might help a loved one with various do's and don'ts. For those that are looking to go beyond just learning more, there's also ways to get support. So again, the National Alliance for Eating Disorders has a variety of support groups. I think at this point, they're offering support groups at least 5, maybe 6 days a week. And they have a variety of different groups, whether they're for parents and caregivers, people who are actively struggling. They have groups for the LGBTQ plus community. They have groups for those that live in larger bodies. So really a variety of things there. And the great thing about these is that they're all clinician led, they're virtual, and they're free. In a similar vein, another organization called Anorexia Nervosa and Associated Disorders also offers peer support group pretty much, let's see here, 3 or 4 days a week, I think, looking at their calendar. And again, they have lots of different types of groups that will really sort of be a good fit no matter who you might be. There's another organization that is called Project Heal. This is a group that is really designed to help you get help. So they do things like providing treatment scholarships. These are they might provide direct cash assistance for those that are in eating disorder treatment, but they also have a clinical assessment program. So if you're not sure if you or your loved one has an eating disorder, you can schedule a free assessment with Project Heal. Above and beyond that, there's also a website called findedhelp.com. And this is a searchable database of individual providers and also treatment centers that specialize in the treatment of eating disorders. You can search this based on your geographical location. You can search it based on your insurance type, the type of treatment that you're looking for. And the nice thing is that you'll see on the screen, of course, when you visit as well, that there's a toll-free number for their helpline. If for some reason you're coming up with a bunch of goose eggs, there's nothing in your area, there's nothing with your search parameters, you can call that number and they can assist you because they're trained clinicians who are on that line who oftentimes have other information at their disposal and may be able to help you get connected with treatment. Lastly, I want to make one plug. Given that I said that we need more research, we need to understand these conditions better, there's an opportunity for you and your loved ones to be involved in this groundbreaking research. So the National Center of Excellence for Eating Disorders that I head up is an organization that's physically based at the University of North Carolina at Chapel Hill, where I'm faculty. There is a world-renowned researcher at UNC by the name of Cindy Bulick, who is the foremost researcher in the genetics of eating disorders. And she is actually leading the world's first genetic study looking at ARFID, and they are looking for people to contribute to their research. So I have provided the website and the hyperlink to that research study so that you can learn more, see if you're eligible. It's all stuff that you can do at home, and it helps to contribute to the science so that we understand these conditions better. So I wanted to leave with that particular plug in case you're interested. But at this time, I'd love to be able to transition over to any questions that might be coming in. And I'm happy to have a discussion about whatever feels relevant. Thank you so much for your attention today.
Thank you so much, Dr. Peat, for such an illuminating presentation. Before we start the Q&A, I'd like to share the final results from today's poll question. How has having ADHD impacted the ability to manage an eating disorder for you, your child, or your patients? Here's what you said. 23% said challenges with impulse control and emotional dysregulation. 20% said increased difficulty in establishing and maintaining routines. 18% said difficulty in focusing on and adhering to a structured meal plan. And then 16% said impact of executive functioning on meal prep and planning. 13% said appetite suppression as a side effect of medication. Not too surprising there. Now to your questions. Why are people with ADHD more prone to eating disorders and ARFID in particular?
Yeah, that's a great question. I think, unfortunately, we are so far from really having causal explanations for this overlap. I think some of what has been hypothesized in the literature when it comes, I'll start with binge eating because there's the most information about that, as we discussed. Some of what's been hypothesized is that both conditions are ones that are characterized by impulsivity. People with binge eating are prone to binge eating in an impulsive fashion in much the same way that you might see kind of show up in ADHD. So maybe there's some sort of underlying impulsivity factor that makes somebody prone to developing both ADHD and binge eating. Now, when it comes to atypical anorexia nervosa or ARFID, I think it's really hard to say, especially early on. But if you think a little bit about some of the data that I presented a few slides ago, there was that one study that looked at that sensory subtype of ARFID. And so maybe there's something where kids with ADHD or even adults with ADHD are just sort of more biologically predisposed to have difficulty with sensory characteristics with food. And so maybe that makes them more vulnerable to going on to develop something like ARFID. What I do want to say is that we know that eating disorders are biologically based conditions. These are not something that somebody chooses. These are not conditions that happen just because we happen to live in a toxic culture. Are those factors? Absolutely. But if culture alone was going to be the major factor, then everyone in this culture would have an eating disorder. So I think it's important to really think about some of the biological bases of these disorders and how they might make somebody prone to developing either or both. I know that's not sort of an exact answer to your question, but I'm hoping that it's helpful.
Okay. How do we prevent an eating disorder from developing? Is that possible?
It's absolutely possible. And I love this question. Part of why I love this question is because all of the literature, whether it's just in eating disorders or throughout mental health and really throughout most medical conditions too, would tell us that the earlier we can do something about a problem, the better the prognosis. So prevention is really where it's at. If we can either prevent these symptoms altogether, that's really the gold standard, right? But if we can catch them as early on as possible and prevent them from ever needing to see a specialist like myself, that's also a really important goal. So when we think about prevention, I think a lot of it really has to do with, number one, understanding, is there a family history of eating disorders or other conditions that commonly co-occur? And if so, how do we think about maybe being more mindful about the environment given that underlying genetic risk? When we think about the environment, I think it's really important that we're doing things that help set kids and adults up for success when it comes to their relationship with food and with their bodies. So for those of you in the audience that are parents or caregivers, think a little bit about the way that you talk about your own body in front of your kids. Think about the way that you talk about your relationship with food in front of your kids. They're soaking all that information up. They're learning from you. And so if you are setting what looks like maybe a more balanced or a more healthy relationship with food and with your body, that helps to set that up or role model that for your kids. We also know that things like regular family meals are protective against eating disorders. People that have good access to general mental health services can also be protective against eating disorders. So again, I think a lot of this really has to do with thinking about wellness as a whole, not just the eating disorder symptoms themselves.
Okay. We had, of course, quite a few questions around ARFID in addition to the previous one. So one is, how does one determine if their child has ARFID or he's just a picky eater?
Yeah, that's a great question and one that we get a lot. It's tough, I think, as a parent to maybe tell the difference between picky eating and ARFID because sometimes they can look very similar. Sometimes kids throw tantrums about things because they just simply don't want the crust cut off of their sandwich that day, right? And it upsets them that you did so. Or maybe kids, only like to eat certain vegetables or fruits and nothing else. But when it comes to a diagnosis of ARFID, this tends to be a much more pervasive and persistent pattern. So, for example, this isn't something that happens for a short period of time or only in certain contexts. This tends to be something that is happening day in, day out for extended period of times and often leads to being malnourished. What I would say is that it's uncommon, I think, for most children who are picky eaters to become malnourished. Whereas in ARFID, those rigid food beliefs or those rigid food rules are so entrenched that there's really no moving them, and it's easy for kids to become malnourished. So what I would say is if you are at all concerned or if you're not sure, it's worth getting an assessment. It's worth finding out a little bit more. Talk to your pediatrician, talk to them about how to get linked up with some of the eating disorder resources that might be in your area, or use some of the resources that I provided here today. But I think if you are not sure, it's worth talking to a specialist to either rule in an eating disorder diagnosis or rule it out. And that way you can have some peace of mind.
I had two questions, one from a parent and one from a practitioner. And the parent said, how do you screen for ARFID? And the practitioner said, what tools or questions do you use to screen to help to prompt a diagnosis?
Yeah, that's a great question. So for parents or caregivers, what I would say is that there unfortunately really aren't any validated measures for parents or caregivers to screen for these eating or feeding difficulties. Oftentimes, though, I would say that parents are our best allies in helping to determine whether or not some of these diagnoses are present, specifically in little ones, because it's hard for little ones to be able to describe what their experience is. What I would say is if you're a parent or a caregiver is to just simply make some observations. What are you noticing? What's changing in your child's eating behaviors? What's changing in terms of their weight or shape? What are you noticing in terms of some difficulties with eating? And if they tend to be persistent or you find that they're really pervasive throughout lots of different contexts, that would be a reason to have a further discussion with a healthcare provider. For the healthcare provider who's asking this question, there are a few validated measures looking at diagnosis of ARFID. However, they've mostly been used in a research context. And unfortunately, there is nothing that's appropriate for use in primary care because all of the screening measures that exist for ARFID are probably, I would say, at least 15 items long. So there might be some that are a little bit shorter, but those are really unwieldy for primary care. So I'm not sure if you happen to be in a primary care setting or where you might be working, but there are a few. One is called the NIAS. I can't remember what the NIAS. I can't remember what the acronym stands for. And there's one called the PARDI, PARDI. That's actually an interview. Again, both of those require training so that you know actually how to administer them. So I would say that, again, if you as a provider are unsure, see if you can get them linked up with an eating disorder provider who could do a specialty assessment.
Okay. We had quite a few questions around using stimulant medication, which for some people, the side effect is appetite suppression. But if you have an eating disorder, what can you do in a situation like that? And which do you treat first and how do you treat both?
Yeah, it's really complicated. When I was doing some prep for this talk, I was looking at some of the literature on stimulant use among people with ADHD as well as an eating disorder diagnosis. And the jury's kind of out. I'll just be honest with you all. I don't think there are very clear paths. There was one study that I looked at that indicated that they were actually really successfully able to refeed and renourish children who were on an inpatient eating disorders unit who had ARFID or anorexia nervosa and had lost a significant amount of weight. They were able to weight restore those kids even while they stayed on a stimulant medication. So I certainly think it's possible. I think one of the challenges is that if you are on a stimulant medication, it's just going to require more work to make sure that your child or that your loved one or you yourself are not sort of artificially masking any eating disorder symptoms that might be sort of at bay, right? So if you're somebody who's on a stimulant medication, making sure that you're not just relying on your stomach to tell you when you're hungry. It might be doing things like making sure that there are timers set for meals and snacks, making sure that you're eating by the clock versus just eating by your stomach, so that you're not inadvertently maybe exacerbating an underlying eating disorder.
Okay. Someone asked, how do we support our children who are going through these struggles? What should we say or not say to them?
So one thing that immediately comes to mind for me is that if you are a parent or a caregiver who is already noticing or is aware that your child is struggling in this way, that's the first step is just having that observation and being able to identify that this is what's going on in your child or your loved one. I would say, secondly, the feast organization that I outlined in the presentation has a ton of information because it was really developed and is currently overseen by people who have sat exactly where you have, parents who have been in the struggle of an eating disorder with their children, and they're there to help provide community, create supportive resources. So I would encourage you to really take a look at their resources, which are also free. But generally speaking here, what I would say is that oftentimes what is most important is a sense of stability and a sense that they're not alone, right? When it comes to fighting this eating disorder, one of the things that often gets done for children and adolescents with these conditions is a reminder that who you're fighting or what you're fighting is the eating disorder and not the kid. It's so important to create that space between the two because the enemy here is the eating disorder, not your kid. And so a reminder of things like, an eating disorder is a condition that sort of hijacks your brain. It doesn't allow you to think the way that you normally do. It doesn't allow you to process your emotions in the way that you typically do. And I'm sure that feels really hard and scary. Let's talk about that, right? But I think reminding both yourself as the parent and also your child that it's the eating disorder that's doing all of this, that you are fighting that eating disorder together, and that you'll do what it takes to really get them to the other side.
Okay. Someone asked, how young can a person be to receive a diagnosis of ARFID or frankly, any eating disorder?
Yeah. It's complicated because especially when we get into the very little ages, it's so hard for little kids to be able to articulate what some of their experience is in ways that sort of map onto our diagnostic criteria, right? I will say that we have seen eating disorders in children as young as age 6. I know some clinicians have probably seen eating disorders in children younger than that. I think what gets murky on the lower end of that age range is the extent to which it's an eating disorder or maybe some other sort of feeding disorder, right? Like there might be things like failure to thrive, for example, that isn't an eating disorder, but it may sort of present as one. So I think it gets really complicated. What I would say is that in those really young ages, I would work very closely with your pediatrician and other specialists if there are questions. But realistically, we don't necessarily have a floor for eating disorder ages.
Okay. Someone writes that she works a lot with adopted kiddos. And they're exposed to trauma, many of them, and they have eating disorders. And she's asking what causes this, or what's the connection, I should say.
Sure. Yeah. I think that overall, if you look at the literature on eating disorders, we know that there tends to be a real predominance of folks that have a history of traumatic experiences, whether that's in childhood, adolescence, or adulthood. It doesn't really matter age range. We just know that there tends to be a lot of overlap between eating disorders and trauma. In terms of why that might be, I think the causal reasons are the million-dollar questions, right? And I don't know that we necessarily have answers to that in this moment. What I will say is that for many people, their traumatic experiences are things that almost irrevocably affect the way that they regulate their emotions, the way that they have a sense of safety in the world, the way in which they may interact interpersonally with other people. And all of those things are actually very important when it comes to eating disorders. So there are several theories looking at eating disorder behaviors as a way to regulate emotions, for example. Binge eating might be something that you do when you're feeling really upset or anxious, and it makes you feel better for a short period of time. There's also indication that things like losing weight or becoming, sort of more normative in terms of what society wants you to look like can also be rewarded and make you feel maybe a little bit more safe in your environment, more accepted by your peers. But above and beyond all of that, eating disorders are conditions that thrive in secrecy. If they were conditions that everybody wanted to shine a bright light on, then I think people would seek treatment a lot more readily. But because of that, when you add in the piece of trauma where there's inherently a lot of shame and a lot of secrecy, it just creates a clinical picture that's much more complex. So, and again, not sure that it's a direct answer to the question that you have, but I'm hoping that it kind of provides a little bit more context there.
Mm-hmm. How do you feel about exercise addiction? Is this a sign of anorexia? Someone asked.
Yeah, The term exercise addiction itself is something that's more of sort of a colloquial term than it is like a clinical diagnosis. What I would say is that people who have maladaptive exercise patterns, you might see that regularly in something like bulimia nervosa, where the exercise is actually the way that they're compensating for the binges. And we also very commonly see it in anorexia nervosa, both threshold anorexia nervosa and atypical anorexia nervosa. You can see that sort of maladaptive exercise relationship where folks are exercising even if they're sick or injured, or people that push themselves to the very limits, even if it's contraindicated to their health because they're not eating enough to really fuel that activity. So what I would say is it may not necessarily be something that is like a slam dunk in terms of whether or not somebody has an eating disorder. It is something that often shows up as part of the clinical picture.
Mm-hmm. Okay. We had a few questions around how can we break the influence of social media inspired diet, celebrity, beauty culture?
Boy, that's like a whole other presentation. It's an excellent question and one that we can spend the whole day talking about. What I would say is that first and foremost, have a conversation with your kids about social media. Have a conversation with them about what they're looking at and encourage them to be savvy consumers of the information that they're seeing. So you might see something that, what somebody eats in a day. Well, what tells you that they're an expert? What tells you that the information that they're giving you is safe or reliable in comparison to somebody else, right? Have them sort of do a little bit of that critical thinking, again, age appropriate, right? I think also be aware of what you as a parent are able to control. Many of the social media companies have parental controls that you are able to kind of oversee in some way. And then certainly there are some federal movements afoot to make sure that parents and caregivers have a greater sense of knowing how to protect their kids from some of the harms that are out there. But it's a tricky space, that's for sure.
Yeah. Loaded space.
Absolutely.
Someone asked, how do we stop emotional eating? When we get upset, we eat something, we comfort ourselves in this way. How can we break this cycle?
Yeah. It's a really common phenomenon. And I think I might answer that question a little bit differently than you might anticipate, but I might actually just sort of offer that emotional eating in and of itself is not something that is necessarily bad or an eating disorder. Almost everyone in the world will experience emotional eating at some point in their lifetime. That doesn't mean everyone in the world has an eating disorder, right? It's sort of a human experience. What I would say is that if you're concerned that it's your primary coping mechanism, or if it's the thing that you go to over and over again, what I would think about is maybe getting involved in some general mental health counseling, or maybe even some medications to help reduce your vulnerability to that emotional eating. Are there certain stressful situations that tend to trigger that for you? How can you maybe address some of that proactively so that you're not as heavily impacted afterwards? Are there other coping strategies that you can rely on or develop with the help of a therapist or a loved one to help get you over the hump? Because usually the emotional eating itself is not the problem. It's the underlying things that make you vulnerable to it. So if you can address some of those pieces, sometimes you'll see better success.
Okay. And for our last question, we have two similar questions. One is, my teenage son won't eat more than 500 calories a day. What can I do? And then a similar question was, my teenage son is how do I know if he has an eating disorder? How does it manifest typically in an older teen boy?
Yeah. I wish I had a typical of what it looked like in teenagers or boys. What I would say is that if you as a parent or a guardian or a loved one are concerned, it's worth being in touch with your pediatrician or any of the resources that I provided here to get some additional assessment, especially if you're noticing that there's a dramatic change in their eating, dramatic changes in their weight, irrespective of what their starting weight was. It's worth getting an assessment because it's really hard to tell, is this just sort of an oddity in their eating versus a more pervasive problem without working with a specialist. So I would say it's so important to pay attention to your gut in terms of something is telling me something is wrong here, something is off here, this isn't normal for my kid, and then work with your healthcare providers to help get you the answers that you might need.
Is there a difference between how these symptoms might manifest between girls and boys?
Great question. I don't know that we have actually gotten that specific, especially when it comes to ARFID or for atypical anorexia nervosa. I would say that restriction is restriction is restriction. Kids will cut out huge numbers of calories, or they'll skip meals and those sorts of things. So I think it really tends to look very similar, whether it's boys or girls. I would say that maybe the major difference is that sometimes it is more notable in boys because it's expected that they're supposed to be eating a lot, or they're supposed to have much bigger appetites than girls do. So sometimes it might be more socially acceptable for girls or for women to eat less or restrict, but it's less socially acceptable for men and for boys. And so sometimes it might stand out a little bit more.
Yeah. Okay. Well, Dr. Peat, thank you so much for joining us today and for sharing your expertise with our ADHD community. We really appreciate it.
Thank you for having me. It was a pleasure.
And thank you to today's listeners. If you would like to access the event resources, visit attitudemag.com and search podcast number 494. The slides and recording are posted a few hours after each live webinar. If you're listening in replay mode, simply click on the episode description. Please know that our full library of Attitude webinars is available as a podcast. It's called the ADHD Experts Podcast, and it's available on all streaming platforms. Make sure you don't miss future Attitude webinars, articles, or research updates by signing up to receive our free email newsletters at attitudemag.com/newsletters. Thanks, everyone. Have a great day.
For more Attitude podcasts and information on living well with attention deficit, visit attitudemag.com. That's ADDITUDEMAG.com.